Now, some of the salient points about thromboembolism in pregnancy. Remember that pulmonary embolism is a leading direct cause of maternal death in the UK, and relative risk of VTE in pregnancy is increased 4 to 6 fold. It is higher in the puerperium, but the absolute risk is 1 to 2 women per 1,000. So, to prevent this, prophylaxis for women, those who are at a high risk to develop VTE, it should begin early in pregnancy. And the risk for VTE, it increases with gestational age, and the risk of VTE is maximum just after delivery. So we know that pregnancy is a hypercoagulable state, and there is a change in all the clotting factors in pregnancy. So let us see how these clotting factors change. So platelet count, it decreases. Actually, there is no decrease in the production of platelet count, but because of the physiological hemodilution, though production is increased, the total platelet count appears to be decreased. Now factors 2 and 5, they remain the same. Fibrinogen, factor 7, 8, 9, 10, 12 and von Willebrand's factor, these increase. Factor 11 overall remains the same, sometimes it might decrease. Factor 13 increases, though sometimes it might decrease. Antithrombin 3 remains the same, protein C remains the same. Protein S decreases, heparin cofactor increases and D-dimer increases. Now in these you should remember that protein C and protein S, these are the two naturally occurring anticoagulants in the body. So how do you determine the risk? Because in the paper you must have seen that what is the score for these women. So remember that there are a lot of medical conditions which are associated with increasing risk of VTE, and according to the risk they have been given a particular score. So pause the video here for a minute and go through the slide. So the condition that is marked in red, that is previous VTE, except for a single event related to major surgery, it has a score of 4. Then the one marked in brown, they are all a score of 3, and then the yellow ones are a score of 1. Now here you have to see that obesity, it is either 1 or 2. So obesity more than, like whenever the BMI, remember it is BMI, more than 30 has been given a score of 1, and whenever it is more than or equal to 40, then it is a score of 2. So these are all the antenatal factors. Now obstetric, these are the factors. So most of them are 1 except an emergency cesarean section or a section in labor has a score of 2. And then there are some factors which are transient. So like any surgery that you are doing in pregnancy or in the puerperium, it has a transient risk factor. So the score is 3. That means only for that particular period of time that factor is high risk for venous thromboembolism, and once that event is over, then you need not calculate it as a risk factor for venous thromboembolism. Now OHSS, as you can see here, only in the first trimester it has a score of 4. So any woman who is undergoing IVF, she develops OHSS, she needs to be given thromboprophylaxis only in the first trimester. After the first trimester, if she still has more factors or more risk factors, then you need to continue the thromboprophylaxis, otherwise it can be stopped. So depending on the score, when do you start thromboprophylaxis in pregnancy? Remember, in the antenatal period, only when it is more than or equal to 4, you will consider thromboprophylaxis in the first trimester. When the score is 3, then you will start from 28 weeks. And if postnatally the score is 2 or more than 2, then you will consider thromboprophylaxis at least for 10 days. Any pregnant woman, whenever she is admitted to the hospital for a prolonged period, so prolonged period means for a period of more than 3 days, you need to give her thromboprophylaxis for the time of admission. Once she goes home, then you need not continue the thromboprophylaxis. So any woman who is in the postpartum, we saw that it is a score of 2. Now if this woman gets admitted in the puerperium, then also she needs thromboprophylaxis for the period of admission. Another thing to remember, any woman who has at an identified risk of bleeding, okay? So here you have to balance the risk of bleeding and the thrombosis, discuss with this a hematologist, and then decide whether you want to start thromboprophylaxis for her or no. Now this is another chart which is very important. In this chart they have given you all the factors in the antenatal period, in the postpartum period. So this is another slide that needs to go to your study wall, and read the slide carefully so that you will know how you are going to calculate the risk and the score, and then decide whether you will start thromboprophylaxis or not. A general rule to remember is that any woman who is taking thromboprophylaxis from 28 weeks of pregnancy, she will usually continue it for in the postpartum period. So if it is an intermediate risk, she continues it for 10 days, and if it is more than that, if it is a high risk, then she continues it for 6 weeks. Now we have a scenario here. You have a lady, 35 years old. She has been posted for an elective cesarean section for breech presentation at 39 weeks. She had an episode of pulmonary embolism at 32 weeks, following which she is on a therapeutic dose of low molecular weight heparin. She has taken her last dose of low molecular weight heparin at 10 a.m. today. So what is the best time or the safe time for her to undergo a regional anesthetic for the surgery? Now to decide this, you have to know at how many hours after a prophylactic dose, or how many hours after the therapeutic dose of low molecular weight heparin can you give regional anesthesia, that means spinal or an epidural. General anesthesia can be given with due risk even if it is a very short interval after she has taken a therapeutic or a thromboprophylactic dose. Okay. So if the woman has been planned for a vaginal birth, she has to be explained that if she feels that there are signs and symptoms of labor, or she has vaginal bleeding or leaking, she should not inject herself with the dose of low molecular weight heparin, and she should report to the hospital immediately. In the hospital, she will be assessed and then decided whether she can take her dose or not. Now what about surgery? So the prophylactic dose has to be stopped 12 hours prior to surgery, therapeutic dose 24 hours prior to surgery. Now after giving any form of regional anesthesia, if you want to restart the thromboprophylactic dose, then you can start it safely 4 hours after a spinal anesthetic. Remember that you will not give the dose for at least 4 hours after you have removed the epidural catheter, and the catheter should not be removed within 12 hours of the last injection of the thromboprophylaxis that has been given. After a vaginal birth, if the woman does not have any high risk for bleeding, that means there is no postpartum hemorrhage, immediately after vaginal birth you can start the thromboprophylactic dose for her. The therapeutic dose is started a little bit later, after 12 to 24 hours, provided there is no postpartum hemorrhage. Now, which are the agents that are used? So, low molecular weight heparin is the agent of choice both in antenatal and the postnatal period. The dose for this is based on the weight. Remember, it is the booking weight and not the current weight of the patient. It is normally safe to give to everyone, except you have to reduce the dose in women, those who have had renal impairment, and also if there is very severe hypertension, that means a pressure of more than 200 by 110, you will avoid giving low molecular weight heparin. Now, normally when you are giving low molecular weight heparin, it is not required to monitor the platelet count. The platelet count has to be monitored whenever you are giving unfractionated heparin. Anti-10A levels are also not required to be monitored when using low molecular weight heparin. And low molecular weight heparin is safe in breastfeeding, so it can be administered even in the postpartum period. Now, how do you calculate the dose of low molecular weight heparin? So this is the chart which you have to know. So it is based on the booking weight of the patient, and remember there is a different dose for enoxaparin, dalteparin and tinzaparin. You have to keep reading this chart every day so that when you are near the exam, you know it by heart. So that was all about thromboembolism. Now coming to acute thrombosis. So you can have either a deep vein thrombosis or a pulmonary embolism in pregnancy. What are the signs and symptoms of deep vein thrombosis? The lady can come to you with leg pain and swelling in the lower limb. It is usually unilateral. She can have lower abdominal pain if the thrombosis extends to the pelvic vessels, and she can have extension of thrombus into the pelvic vessels, or there could also be development of collateral circulation. Now with pulmonary embolism, the clinical presentation is more acute. She will present with dyspnea, chest pain, hemoptysis, or in very severe cases, she might even present with a maternal collapse. So to decide or to come to a diagnosis and whether you should be continuing with low molecular weight heparin or not, there is a very beautiful diagram or an algorithm given in the guideline, and this algorithm is to be known by everybody. So whenever you have a woman in whom you are suspecting a pulmonary embolism, you will do a thorough clinical assessment. The initial investigations that you have to do are an X-ray chest, an ECG. The blood tests are a full blood count, U&Es and liver function tests. Now, since pulmonary embolism is a life-threatening condition, you can start low molecular weight heparin even on a clinical suspicion, unless there is any contraindication to low molecular weight heparin. That means the woman is allergic or something like that. Okay. So once you have started low molecular weight heparin, then you can go back and do a more thorough clinical assessment. So look whether there are signs and symptoms of DVT. If there are signs and symptoms of DVT, you can do a compression duplex ultrasound of the lower limb. If this ultrasound confirms DVT, there is no need for further testing, and you can continue with therapeutic doses of low molecular weight heparin, because it has been seen in most of the cases that anyone having DVT and presenting with signs and symptoms of pulmonary embolism, usually there is a pulmonary embolism present. So no need for further testing. But if there are no signs and symptoms of DVT, or your ultrasound doesn't confirm the presence of a DVT, then go back and have a look at your X-ray chest. Is the X-ray chest normal or not? If the X-ray chest is normal, then you can do a VQ scan or you can do a perfusion scan. If the X-ray chest is not normal, you can do a CTPA. So your perfusion scan or your CTPA, it will confirm or refute a diagnosis of pulmonary embolism. If the diagnosis of pulmonary embolism is confirmed, continue therapeutic doses of low molecular weight heparin. If diagnosis of pulmonary embolism is not confirmed, even on the VQ scan or the CTPA, but your clinical suspicion of pulmonary embolism is very high, you can consider an alternative diagnosis, or you can repeat testing but still continue with low molecular weight heparin. If your clinical suspicion of pulmonary embolism is low, you will discontinue low molecular weight heparin and consider any alternative diagnosis. Now about VQ scanning, remember it has an increased likelihood of childhood cancer because the exposure to the fetus is much more than that for the mother. With CTPA, the risk of the mother developing breast cancer later on is more. So you will always involve the woman in your decision making whenever you are doing a VQ scan or a CTPA, and always get an informed consent wherever it is feasible. Now what about the role of ECG? So 41% of the times it has been seen that these women have an abnormal ECG. So ECG does have a diagnostic role in confirmation of pulmonary embolism. ABG is of limited diagnostic value, so not advocated to be done. X-ray chest, whenever it is abnormal, in addition to diagnosing a pulmonary embolism, it can also identify if the woman has pneumonia, if there is pneumothorax, or there is a lobar collapse. Whereas, and in pulmonary embolism, what would be the signs that you would be seeing on an X-ray chest? You can have atelectasis, that means there is a collapse of the lung tissue. There could be effusion. There can be focal opacities or regional oligemia or pulmonary edema. D-dimer is usually not done because normally D-dimer advances with advancing gestation or the multiple pregnancy whenever the lady has undergone any operative delivery or a C-section and following a major PPH. So even if you have high levels of D-dimer, they are not really going to help you in clinching a diagnosis of pulmonary embolism. So what is the initial treatment of venous thromboembolism in pregnancy? It is low molecular weight heparin immediately unless the diagnosis is excluded. So why low molecular weight heparin? Because it is more effective and there is low risk of repeated or recurrent venous thromboembolism with therapeutic dose. Also, there is a lower risk of hemorrhagic complications. Mortality is lower than unfractionated heparin in non-pregnant women, and we know that with use of heparin there could be a risk of osteoporosis. So low molecular weight heparin is the preferred drug. Now this is a chart which is telling you the dose of low molecular weight heparin, which is therapeutic. Remember, it is different than the prophylactic dose, so you have to remember this chart again. And for tinzaparin, the therapeutic dose is the same for all weight categories. It is 175 unit per kg given once daily. As for the prophylactic dose, if the creatinine clearance is less than 30 ml per minute, you will use lower doses of enoxaparin or tinzaparin. And remember, even for the therapeutic dose, the weight is calculated based on the booking weight or early pregnancy weight and not the current weight of the woman. Now, which are the blood tests that you will monitor whenever you are giving heparin? So, women who have a weight of less than 50 kg or more than 90 kg, or women with renal impairment or recurrent VTE, for them you will be doing these blood tests. Routine measurement of peak anti-10A activity is not recommended. Routine platelet count is usually not carried out, and blood tests you will do post-operatively. And on women, those who are on unfractionated heparin, for these women you will be doing a platelet count every 2 to 3 days from day 4 to 14 or from the day you have started heparin until heparin is stopped. So women, those who are on low molecular weight heparin, for almost all the categories of women except those which I have mentioned above, you will not be doing any routine blood tests. Let us see a few questions that would appear in your exam. So what are the categories of body weight that require routine measurement of peak anti-10A activity for women who are under treatment with low molecular weight heparin for acute venous thromboembolism in pregnancy? So here the option is, if you remember the previous slide carefully, women those who weigh less than 50 kg, those who are weighing more than 90 kg, these are the women who require routine measurement of peak anti-10A activity. Okay. You have another woman who is 28 years old, her BMI is 25 and she has booked into the antenatal clinic 12 weeks ago. 2 years previously, she had a confirmed iliofemoral thrombosis in her left knee after major knee surgery. What advice would you give her regarding thromboprophylaxis? So you have the various options here that you can use LDA, you can give it for 6 weeks or you can give it throughout pregnancy, then give it from 28 weeks for 6 weeks postpartum, use LDA and low molecular weight heparin throughout pregnancy, 6 weeks postpartum, or use low molecular weight heparin only if other risk factors arise in pregnancy. Now, if you see the scenario carefully, this woman, her age is 28, so her risk is 0. BMI 25, also the score is 0. But she has a provoked iliofemoral thrombosis. So if it is a provoked iliofemoral thrombosis, her score becomes 3. And we know that if the score is 3 in pregnancy, she will be put on a thromboprophylactic dose from 28 weeks of pregnancy and for 6 weeks postpartum. So the answer here is C. Okay, it will either be 6 weeks or 10 days postpartum, depending on what is her score in the postpartum period. Okay. Now you have a woman who is 24 years old. At 12 weeks in pregnancy, she presents with a confirmed venous thromboembolism. So what would you advise her regarding her treatment? Remember that this woman has venous thromboembolism. In this pregnancy, she is a very high risk case. So for her, you will start for her therapeutic low molecular weight heparin and continue it the entire pregnancy. You will not start therapeutic dose and then after 3 weeks go back to a prophylactic dose, because then that is associated with recurrent venous thromboembolism. And here, of course, low molecular weight heparin is the drug of choice. So for entire duration of pregnancy, she will have a therapeutic dose, or the recommendation is that she has to take it to complete at least 3 to 6 months of treatment. Another scenario, you have Mrs. Annie. She is a primey who is 30 weeks pregnant. She presents to A&E with acute onset of shortness of breath and chest pain. She has just travelled a long haul flight, that means 12 hours flight to the UK. She has been commenced on therapeutic low molecular weight heparin, that is dalteparin, pending investigations to rule out a pulmonary embolism. Her booking weight is 66 kgs and she currently weighs 76 kgs. So what is the correct dose of dalteparin that she should receive? Now remember, here the catch is her booking weight is 66 and she currently weighs 76 kg. So what is the answer that you have chosen? The correct answer is 12,000 international units daily, because remember, you have to choose the dose depending on her booking weight and not her current weight. Okay, so please go back to the slide where I have shown you the dosage chart, and then you can confirm what is the correct dose that she needs to take, but it has to be on her booking weight and not her current weight. Now the same lady, Mari, who is 30 weeks pregnant, she has presented to the A&E with acute onset of shortness of breath and chest pain. She has just travelled by a long haul flight to the UK. So which of the following investigation is not appropriate for a suspected pulmonary embolism in pregnancy? The choices are a CTPA, chest X-ray, D-dimer, ECG and VQ scan. So what is the answer that you have chosen? According to me, a D-dimer is not the correct investigation that has to be done, because we know that in pregnancy there is a progressive rise in D-dimer levels with advancing gestations, and also the levels are increased in multiple pregnancy if the woman has undergone a CS or she has had a postpartum hemorrhage. So a positive D-dimer test in pregnancy is not necessarily consistent with a venous thromboembolism. So D-dimer testing is not performed in the investigation of pulmonary embolism in pregnancy. All the answers and the explanations or the evidence that I have given to you is based on the guideline number 37A and 37B. So points or the important type of questions that you would be getting on venous thromboembolism in pregnancy. Thank you for watching the video. I hope you have found it helpful, and good luck for your exams.